We hear a lot about the need to control the amount of acids that we have in our diet in order to control bone health. We have meetings that discuss whether or not we are eating the foods that we should be eating in order to maintain normal body chemistry. Which takes us to the question, what is the issue with alkalosis and what is the issue with acidosis? What is the issue with changes in body pH? And what does it have to do with pathophysiology? Well, let's talk about that.
Warning! The following presentation contains information that might contradict what you have previously heard, or believed to be true, about how the human body works, and contains material that is not suitable for closed-minded individuals. Enjoy!
So when we're talking about body pH, what we're really talking about is the ability to maintain a range of pH that is somewhere between 7.35 and 7.45, which is our normal homeostatic range for pH. Anything above 7.45 is what's referred to as alkalosis. Anything below 7.35 is what's referred to as acidosis. And this is where we have to constantly remind ourselves that we need to stop trying to acidify or alkalize our body. Our lungs and our kidneys are constantly trying to compensate for changes in pH that we might have due to what we eat and what we are doing. We start looking at this acid-base regulation. What we're really trying to do is, once again, maintain that normal pH, 7.35, 7.45. And this is done through maintaining what's referred to as the anion gap. That's the difference between the cations, the positive charged ions, and the anions, the negative charged ions within the plasma of the blood. Most of this is done through the regulation of the bicarb equilibrium reaction. This is where the carbon dioxide that our cells are producing will interact with the water in the plasma to produce carbonic acid, which will degrade into bicarbonate and the hydrogen ion in an equilibrium. That is where we're going to be constantly having an equal amount of carbonic acid and bicarbonate within the plasma. This equilibrium is combined with the chloride ions that we see within the plasma in order to establish the anion gap. That is the greater amount of anions, negative charged ions, relative to positive charged ions within the plasma. Why is it important? What do we have to worry about in terms of changes in pH? What do we have to worry about in terms of changes in that anion gap? Well, the first thing we have to worry about is changes in the ability for our red blood cells, our erythrocytes, to move oxygen around, where changes in acidity are going to cause right shifts and left shifts to occur. The worst of these are the right shifts, which occur when we have greater amounts of acids within the blood, where we're becoming acidified, or we're becoming acidotic in terms of our normal metabolic processes, which can lead to hypoxic conditions for the tissues. Most of this shifting that we see in terms of right shift and left shift is based off of whether or not the hemoglobin molecules within the red blood cells need to be used for compensation, for buffering, in order to help maintain that anion gap, that normal pH. The other thing I have to worry about is the change in enzyme activity based off of changes from optimal performance. This optimal performance, optimal pH, is going to impact enzyme activity, and any change in enzyme activity is going to change how the enzyme is going to function and whether or not our metabolism will be at optimal levels. This is why we need to make sure we maintain that 7.35 to 7.45 range of pH. Now, based off of where we're at in the body, this optimal pH is going to vary, such as in the stomach, where we're going to have an optimal pH that is very close to 1 to 2 because of the acid that is being produced by the stomach, based off of the function the stomach happens to have. However, for most of the other cells and other tissues within the body, that optimal pH is going to be at 7.35 to 7.45. The other thing that's going to change place is going to be the electrolyte concentrations that we see, as well as the excretion rates of electrolytes based off of changes in pH in an attempt to compensate for the varying levels of hydrogen ions or hydroxyl ions, that's the H plus ions or the OH negative ions, that we happen to see within the plasma based off of changes in the metabolites that we see in circulation. This change in electrolyte concentration, this change in electrolyte excretions is going to impact the functions of all of the tissues of the body, in particular the excitable tissues, the muscle cells, the neurons, the bones, just to name a few, which we talked about when we looked at issues with electrolyte concentrations. The other thing we have to start looking at is okay, How can we go about making sure that we're not going to have an irregular acidotic or irregular alkalotic condition? And this is where we have to rely upon our buffers. The buffers are going to temporarily bind onto the molecules that will either produce hydrogen ions or remove hydrogen ions from the plasma. This, for most of us and for most of the buffers, will be acting as weak bases. That's where they're going to temporarily bind onto the molecules that will provide hydrogen ions to the plasma. Well, if you can act as a weak acid, that is where they're going to allow for additional hydrogen ions to be released based off of conditions. These include the protein buffers, the bicarbonate buffer system, the phosphorus buffers, as well as the ammonia and ammonium buffers. All of these buffer systems will be found within the plasma as well as within the various tissues and cells of the body, so as to be able to maintain normal pH within the fluids of the body as measured within the plasma. So, what are some of the pH conditions that we're going to run into? Well, whenever we start looking at pH conditions, we're going to be looking at it based off of changes in either carbonic acid, H2CO3, or bicarbonate, HCO3 negative, or the concentration of carbon dioxide, the PCO2, that we happen to see within the arterial blood, where we have normal values of PCO2 at about 40 millimeters of mercury pressure, normal concentrations of carbonic acid and bicarbonate of about 24 milliequivalents per liter. Any change in those values, where we're going to see fluctuations in terms of higher or lower values of PCO2, higher amounts of H2CO3, carbonic acid, which is going to lead to the acidotic condition, or higher amounts of bicarbonate, HCO3 negative, which is going to lead to the alkalotic condition, is going to give us acidosis and alkalosis. Anytime we talk about acidosis, we're talking about changes in the concentration of hydrogen ions. Now, for physiology, it's not really hydrogen ions by hydrogen ions themselves. What we're really looking at the accumulation of metabolites that can donate hydrogen ions into the plasma. These are the metabolic acids. A lot of times we talk about the metabolic acids coming away from normal cellular metabolism as being things like lactic acid, but we also have things like amino acids, fatty acids, ketone bodies that are all going to have this ability to donate hydrogen ions into the plasma. Outside of the plasma, these molecules may not actually be acidic. However, in the plasma, because of the amount of water that's available to them, they will start to act like acids. Opposite of that is alkalosis. Alkalosis is where we start to lose hydrogen ions. But once again, in physiology, we're not actually losing the hydrogen ions. What we're doing is we're accumulating molecules, metabolites, that can accept freed hydrogen ions from the metabolic waste or the metabolic acids that happen to be in the plasma. And so we start looking at alkalosis, we're talking about having an accumulation of those buffers that are meant to keep us from going into an acidotic state. Now, when we start looking at this alkalosis and acidosis, what we're really talking about metabolic or respiratory conditions. And so when we start talking about respiratory conditions, we're talking about respiratory acidosis or respiratory alkalosis that is not being compensated by lung action, but may be due to lung action. When we start talking about metabolic alkalosis or metabolic acidosis, we're talking about things that are not being compensated correctly at the kidneys in terms of excretion of metabolites, where we're going to try to compensate for the metabolic states by actions at the lungs, and we're going to try to compensate for respiratory states by actions at the kidneys. So when we start talking about this acidosis and this alkalosis, we're really talking about is what is the relationship relative to normal pH? And we usually about 7.4, which is that midpoint in that range, in order to determine acidosis or alkalosis. So what happens if we have a pH that's less than 7.4? We're going to have acidosis. If we see it with an elevated level of CO2, we can designate this as being a respiratory acidotic condition. Respiratory acidotic condition is typically seen with hypoventilatory exchanges. This is low gas exchanges at the lungs. Things coming away from airway obstructions, acute or chronic lung diseases, sedatives, opioids, or narcotics that are reducing my rate of respiration, or having weak respiratory muscles not allowing me to have full ventilations taking place within the lungs. This is where we are not clearing carbon dioxides, but we're also not getting the correct amount of oxygen coming in. That is going to lead to an increased amount of anaerobic metabolism. And the increase in anaerobic metabolism is going to increase the amount of metabolic acids that are being produced by the cells of the body as part of the hypoxic signals that take place. Well, what happens if we happen to have a reduction in CO2? This is where we're going to start seeing a metabolic acidosis condition, where we have methanol poisoning, where we have uremia, where we have diabetic ketoacidosis, where we have lactic acidosis, where we have salicylates that are causing changes in the amount of acids being in circulation relative to the amount of anions in circulation. Compensation here is going to have an increase in anions, but the concentration of anions, the increase in buffers, is not going to be enough in order to compensate for the reduction in pH. We could also see where we have a normal anion gap. This is where we might have things like diarrhea, renal acidosis, or hyperkalemia taking place. We may also see this when we happen to have aerosol inhalation issues coming into play. This is where we might see people who are huffers in terms of a clinical setting, where they're filling up bags with aerosol gases, or people who are in poorly ventilated areas where they are using aerosols in order to paint or to do any type of construction, where we're going to get a metabolic acidotic condition coming into play. So that's the acidotic state. What about the alkalotic state? Alkalotic state is going to come into play when we start getting above 7.4. And once again, we start looking at the CO2 levels. What happens if I am above 7.4 and have high amounts of CO2? Well, we're going to start looking at metabolic conditions, such as having excessive amounts of diuretics, excessive vomiting, excessive antacid, hyperaldosterone will all come into play as it relates to that metabolic condition, where what we're doing is we're causing a change in our anion gap by increasing the excretion of acids from the body. Now, what happens if I happen to have this alkalotic state, but have a low CO2? This is going to be a respiratory issue. What are going to be the causes here? Hyperventilation. Early altitude exposure or early amounts of sickness can come into play here. Excessive aspirin ingestion can come into play here. Now, one of the things that we didn't look at when we started looking at this alkalotic condition in terms of the metabolic state, as well as the acidotic conditions in terms of the metabolic state, is diet. Increased amounts of acids in the foods can cause acidotic conditions to come into play. People who follow a vegetarian diet can have a higher risk of becoming alkalotic. People who take dietary pills, particularly the thermogenic pills that have a diuretic effect to it, and follow a vegetarian diet, can have issues with alkalotic conditions. So if we start looking at, okay, what can we do in terms of a summary? Well, respiratory acidosis, we're going to have low pH, high CO2, but normal bicarb. Respiratory alkalosis, we're going to have high pH, low CO2, but normal bicarb. Metabolic acidosis, low pH, normal CO2, lower than normal bicarb. Metabolic alkalosis, high pH, normal CO2, higher than normal bicarb. So if we want to look at it in terms of a very quick summary of how do I know whether it is a respiratory or metabolic alkalosis or acidosis, I basically look at what's happening in terms of the changes relative to pH in regards to the CO2. So what are some of the normal compensations that we're going to have to this condition, and what do we have to worry about in terms of having uncompensated issues leading to alkalosis and acidosis? When we start looking at the kidneys, respiratory alkalosis is going to be met with altered reabsorption of metabolic acids and altered excretions of bicarbonate, so as to ensure that we get the normal pH coming away by increasing the excretion rates of our alkaline substances, our bicarb, while retaining metabolic or metabolites that can lead to an increase in hydrogen ions What happens if we have respiratory acidosis? Well, we're going to alter our exchange of sodium and hydrogen, and we're going to alter the absorption of bicarb. We're going to increase the absorption of bicarb, increase the secretion of hydrogen ions, and utilize our hydrogen and sodium transporters in order to bring sodium back into the body while excreting hydrogen. When we have issues with those changes in excretions and reabsorptions, that's where we're going to start having the alkalotic and acidotic uncompensated issues that come into play. Well, what about at the lungs? What kind of compensations are we going to have? Well, we're going to primarily be compensating for the metabolite issues. So metabolic alkalosis and metabolic acidosis. For metabolic alkalosis, we're going to alter breathing. We're going to try to slow our breathing down, and we're going to use rebreathers. We're going to try to change mental cues so as to reduce anxiety levels. Once again, most of that respiratory alkalosis is going to come about due to hyperventilation. And most of our hyperventilation is going to come about due to anxiety and or stress. This is where we can do tricks like breathing into the bags, using rebreather masks if we happen to be in the hospital, breathing into our shirts as an attempt to change CO2 levels so as to get us out of that respiratory alkalotic condition. What about respiratory acidosis or metabolic acidosis compensation at the respiration areas? This is where we're going to become reliant upon our triphasic response. This is where we're going to increase our tidal volumes, increase our respiration rates, increase our vital capacities in compensation for the increased amounts of metabolites that need to be cleared so as to get pH back to normal. Where we have increased metabolic activity, that increased metabolic activity is going to reduce pH due to the accumulation of metabolic acids, lactic acid, pyruvate, ketone bodies, amino acids, fatty acids that get freed up during exercise or during periods of stress, where by changing our ventilation volumes, by increasing the amount of gas being exchanged, we're able to compensate for those issues. Well, thanks for listening. Thanks for watching. Hopefully, you got a little bit out of the talk about alkalosis and acidosis. Please make sure you check out the podcast as well as the other YouTube videos that we have on the issues of alkalosis and acidosis, as well as the other pathology videos that are out there. And there are more to come. Make sure to follow us on all of the various platforms here on YouTube, as well as on the podcast. The written stuff in Substack, as well as the quick takes on Instagram and on Threads.